the chairman of SHA is here. He's smiling because he knows that's a possibility. Right?
Yes. But our toll-free line doesn't need any airtime.
So there's a toll-free line
It's a
for SHA.
toll-free line.
And you'll tell us about it as we continue this conversation. Welcome, Dr. Mohammed.
Thank you very much.
Yeah.
Thank you, Eric and Siti.
Karibu sana.
Good morning, viewers and listeners.
Karibu sana. We want to have a conversation with the chairman of the Social Health Authority. He is the man who is now spending sleepless nights, and he's the man who many people are blaming for the kind of sleepless nights that they are also spending at home. So we'll first have a conversation with you to just understand the very many things that you're doing to address the very many emerging concerns in the rollout of SHA. And then we'll open up the phone lines and let people tell you what they're dealing with on the ground. So if you've got an issue that you'd like the SHA chairman to address, we'll tell you when. Please call and speak to him and let him respond to this. That's a good thing, Senior.
Thank you. Yes.
Yeah.
We would like to hear what are the issues, and we are ready to solve them.
Very good.
Yes.
Siti, now welcome the Daktari with the day's proverb.
Yes, our proverbs for this week and the following weeks will be from countries that are in the region that we call the Maghreb region. Okay? The country that we are getting our proverbs from, the Kingdom of Morocco. If you told a dog had run off, if you are told a dog had run off with your ear, would you run after the dog or just search for your ear?
If you're told a dog has run off with your ear,
Yes.
would you run after the dog?
You are being told.
Yes.
I thought the ear belongs to you. How are you being told that you are missing something? that belongs to you and that is on your body. So first you have to be sure of who is telling you and what are they telling you that you don't know. And then now you decide whether what they are telling you is correct or not, and follow what you need to do. So you cannot be told you are missing an ear and the ear belongs to you.
So what do you think the message is here from the Moroccans?
That you don't just accept what you are told, you have to verify first.
Before you start running after a dog.
Yes, and that has been actually that
and scaring the dog.
and for me that is the message that I want to pass today to the public. That there is so much misinformation, there is so much fake news that you will end up listening without realizing that you are being lied to. So don't just accept everything that you see in the public domain and assume it's true. So you need to verify first. Even read for yourself. And today I've come with these two documents. I just wanted the public, and these are things that are in public domains. The Act, the regulations, I've left the third one, which is the benefits and the tariffs. And all these three documents are on the websites of kenyalaw.org, on our website. Anywhere, if you search the Social Health Insurance Act, if you search the regulations, if you search the benefits, you will find all. And these are the people I'm talking about too, are people who have access. I'm not talking to the people who are in rural areas who might not be able to get these documents. But the people who propagate the misinformation are people who you expect to at least read and say, yes, this is true, this is false. Yes. That's my challenge. So that we remove...
consume the information for yourself.
Yes, you remove facts from fiction. Yeah. Then now we can have a debate and say, okay, this was not good, or this can be improved, or this is how we should have done.
Okay.
Then we can proceed and say, okay, that is good feedback, and then we see how to incorporate.
Okay.
But there is a lot of misinformation.
For many people,
Yes.
there could be a lot of misinformation in the run-up to 1st of October.
Yes.
In the run-up to 1st of October, we hosted you here. We hosted the minister, we've hosted the PSs, we've hosted the president's advisors on what the rollout of UHC was going to look like, what we expected to see. Come 1st of October, it's now been reality. For many people, it's a reality when they go to hospital and they are told, we don't accept NHIF anymore. And they are told that now, for your dialysis session, we are only giving 2,500 or whatever figure, I'm not exactly sure, and then you have to give the top up. For many, it's a reality when they go to hospital and they are told, NHIF is no longer in operation, it is a new authority, and you don't know the information about it, so you have to pay cash because we don't have information, right? So no matter what kind of information they have, the person that they are going to seek help from says they don't have information, and it ends there. So it's been pain and pain and pain for many.
Yes, there has been a few challenges with a few facilities where they turned away patients or they asked them to pay cash. If you look at the total number of dialysis centers, around 230, you would say maybe around 10 or 20 at most were the ones who are pushing patients away. And the rest were able to continue offering services because you need to realize one thing, and I thank the providers because they understand that service is delivered by the human beings, health care workers, and the hospital, and not a system. So a system is not what treats a patient. It's the hospital and the providers in that hospital who treat. And they understand these administrative issues are things that can be solved even if you don't have clear guidelines on how to go about it. Two, you need to realize that tariffs have been gazetted. So I don't know where someone now, it's no longer a document that you wait for as a provider. Because this is something that's in public domain. The prices are clearly stipulated. So you will find, I don't know where 2,700 came from. So the question you should be asking yourself is, why would a provider say, we are only receiving 2,750? Because even NHIF was paying 9,600. SHA is paying 10,650. Where did this 2,700 come from? Even the first time NHIF started paying for dialysis, it started with 2,500.
Yeah.
It moved to 7,500. Then it became 9,600. So the question is, how did you end up saying it's 2,700 and our tariffs don't come with the contract? They are there in advance, gazetted.
So
on 16th September.
Have you talked to these providers?
Yes. All the providers.
Where did they come up with the figure?
And now you see those are now things that the administration is handling, the management, and finding out why, how, why did they ask money for the patients that they need to refund. There are a few facilities that have already refunded patients. The few
what was the reason for asking for money?
The reason was, and this is also the other challenge that we have had with NHIF, and these are now the things that we want to correct going forward. Suppose you are on dialysis, chronic kidney condition. You are known. You have been given dialysis sessions approved. Administratively, NHIF was approving every session. So the facility needs to pre-authorize and then you proceed. Surely, once you have a chronic condition, no one goes to dialysis for leisure.
Yep.
No patient says, I want to be dialyzed today. I feel like there's something wrong. None. So they moved that to 1 month approval. But where I come from, that is still illogical. Because I know, God forbid, Eric needs 2 sessions. I put it in the system that you are entitled to 2 sessions a week. You pre-authorize yourself by your fingerprint because you have gone. So 1 session is knocked off from that week. You go again,
Same.
1 session is knocked off. The facility does not need to ask, Eric is here, we want to dialyze, please approve. That is repetitive, unnecessary time wastage that can easily be automated and authorized through a fingerprint. Because even you, Eric, you know you have 2 sessions.
Yeah.
If you go twice in 2 days, then you know your 2 sessions are over for this week.
Yep.
And if you receive a message that says facility X is dialyzing you, you know it's not you because you haven't put your fingerprint. So I don't know what they were trying to cap, or they were just maybe having more resources, human resource interventions to justify that we are working. So you see, those are now the things that we need to address moving forward at SHA. Once you are pre-authorized for certain things, conditions, that we know these are chronic, you will need it. And it's not going to end today or tomorrow. Until you get a transplant, or until, maybe God forbid, you pass away. Between then, there's nothing.
You have to get...
You have to be dialyzed. You have to be dialyzed.
Yeah.
You don't have an option. And it's not a leisurely thing that you do.
Dr. Please go ahead. The matters surrounding teething problems, as these were called,
Yes.
are things that are not difficult to understand
Yes.
because it's a new system.
Yes.
There was a whole year.
Yes.
Within that time,
Yes.
all the variables that are involved in accessing health through the SHA system were not unknown because there was the NHIF database that gave you a very clear indication of what it is that people required in terms of service. Now, when you're here, I ask the question, and I'm going back to it about the issue of a pilot. Now, sometimes the word pilot is too general. Whatever system it is that we are talking about, talk about the back end of it. Talk about what it is that people see. Talk about the transition. All these things were talked about. And as we speak now, what was referred to as the teething problem was now the process of actualizing it. I remember when UHC, before even the thinking of rolling it out, was it 5 counties piloted? 4. Sumu,
Machakos, Nyeri, and Siolo.
Now, it is how these things are done. And the understanding is that you already have the system. You are now actualizing it with real people just to see the responses. That is supposed to give you the clear indication of what needs sorting out and what doesn't. Okay. There's also the concept of water under the bridge. We are where we are. Is it possible for the public to understand what it is that has been set in place to A, get information in a timely fashion as to what is working and what is not working and how it is you hope to address it? And when it is addressed, how it is you hope to communicate that it has been addressed. And how, again, you hope to tell the public, this is the manner in which we'd like you to give us feedback as to what is happening, so that we can know firsthand that this is what is actually going on, so that we can actually address it.
Thank you. So yes, we'll say water under the bridge, but there are issues that we had to address as we moved forward. And I have said from the word go, hospitals are the ones who treat patients. And it's not a system that you really have to have for you to say, I'm treating. So what we have done as an authority is just to communicate to the providers that this is what we expect. In the case of a failure of this is the alternative. In the case of a failure of this is also the other alternative on how to proceed. So that's why we had that presser yesterday with the providers, that this is how we will move forward, going forward, that when you face a challenge of this magnitude or a system, and that's why we have the two systems running concurrently currently, both of them. So if this one doesn't work, use this one. This one works, proceed with this one. The two of them fail, use a manual system and continue providing services. So that is how we have addressed. The second thing that we have done is now the public, and which we need to also sensitize and advertise a little bit more, is the call center number, which is toll free, so that they are able to ask questions and get clarifications on what are the issues that they are facing, and their problems are addressed in real time. Similarly, for the providers, we have a different call number so that we separate the two. So providers with their system issues have their own toll, yes. Patients have their own toll. So patients' issues can be solved by the call center, and the providers' issues can be solved by the technical team. So that now is what we need to constantly update on our socials, in our media, wherever we go, so that people understand.
What's the call center number?
I have to check. It's 0800. It's a long number. Okay. I will give you during the break. Then you will put it up, and then people will be able to reach out and get answers and clarifications.
One would assume, Doctor, that
Yes.
you had very many meetings before the 1st of October.
Yes.
In which, just like CT is saying, so you chose not to pilot, you chose to roll it out.
Yes.
But in this decision to not pilot but roll it out,
Yes.
you must have looked at these are the likely areas that we are going to have hitches.
Yes.
We're going to have a system hitch here.
Yes.
We're going to have a lack of information and awareness by various health providers.
Yes.
We do not have contracts with so many hospitals
Yes.
already.
Yes.
And these are hospitals that are serving people.
Yes.
You came from the private sector. You are a leader in the Private Hospitals Association.
Yes.
So you know the pain that the private hospitals associations go through. And therefore, you know that without clarity, the most likely thing they're going to do is not accept. You knew that.
Yes.
So what did you prepare for all those things?
So that's why this is not the first time there has been changes in terms of tariff and in terms of contract. Providers, and as you have clearly said, I was a provider before, used to proceed without any issue because they knew this is just a rollover, a change of prices, a change of contract will come through. And I have told you, out of the 230 dialysis centers, 220 had no issue because they understood it's not the first time there are changes in terms of prices or in terms of contract. And they proceeded and provided services without asking. Starting with Aga Khan that you have mentioned, they gave dialysis and they didn't ask any patient for cash. So that is the thing. You will have a few who might have been maybe new centers, 1 year old, who have never been part of a changeover, are not members of an association. They are standalones. So they don't know what their leaders or their associations have engaged. Because you need to understand one thing. We have 8,900 providers. Now, calling 8,900 providers in one sitting is impossible.
Why is it impossible?
To a meeting, and then you tell them, all of them, to come to Nairobi, and you want to discuss with them.
No, you don't. You don't actually need to do that.
We have engaged them through Zooms as well. We have done digitally. Yes. And I am telling you, the challenge is some of them are not part of those associations. They are standalones, they are lone rangers. So they don't even know what's going on, what's happening. So those are now the ones that we have now to address directly.
So my question is,
yes,
before the 1st of October,
yes,
right?
Yes.
Had you spoken to all the 8,900 providers, all of them, and going forward with SHA, you are dealing with KMPDC, not associations. It is all institutions that have been registered by the Kenya Medical Practitioners and Dentists Council that regulates them. So you have a focal point, KMPDC. Had you engaged the 8,900 providers? So had the 8,900, were you satisfied that the 8,900 providers were ready for the rollout of SHA? Second question, had you engaged with all your other partners in terms of provision of equipment and services to make sure that everybody is on the same page? That you have two systems, we are continuing with the NHIF system, as we roll over into the SHA system, that we shall operate two systems at the same time. Were they all aware?
We have sent memos through the branches.
Before the 1st of October?
Yes. And even after, first, second.
I'm stuck,
no. Even,
I'm stuck
yes,
with it before the 1st of October.
Yes. So there's one thing that you need to realize. Everyone who is on KMPDC list is not contracted by NHIF.
True.
So that's one thing that you have to realize. You have, KMPDC has almost 14,000 facilities on their list.
Yeah.
The reason why everyone is not on board is because of the previous contracting issues that NHIF used to have. It used to take 2 years with many back and forth below the table discussions for you to be onboarded.
And that's why we were told by the PS here last week.
Yes.
That one of the reasons why you're not going that route.
Yes.
And using the KMPDC route.
Yes.
Is that all health facilities that are registered by KMPDC
will be empaneled
into SHA. So we don't need to think about contracts.
It will be empaneled by SHA.
Yes.
Then the second thing is, because you see facilities have the autonomy to be contracted. Contractual obligation is different from being empaneled.
Okay.
So I empanel you, Eric. Eric, you look at my tariff and you say, these prices, it's okay. I'm okay. I can't.
Doc, I get you. But my question.
No, I just want you to understand first so that we are on the same page.
Right.
So it's not a must that we contract you,
yes,
because it's you to decide that you want it to be contracted. So the facilities that have been empaneled or that have been contracted before by NHIF, who you assume automatically will renew their contract, are the ones now who you have communicated with and told them, because the new ones don't have any contract. So they need to be contracted first. They need to return the contracts because they were given the contracts prior to 1st of October.
Okay.
Yes. So the ones that have been on our panel before at NHIF have received and knew that these are the contracts, number one, that they have received.
But they haven't signed.
Some of them signed and returned.
What was the percentage of the 8,900 NHIF providers that had signed contracts by the 1st of October?
All public facilities.
All public facilities?
Yes. And that is
level 2 to level
4,000, almost 6,000 facilities.
Okay.
Yes. 1,400 private had signed.
By the 1st of October?
Yes.
Not by yesterday?
No. Not by yesterday. Because you see, some of them, and this is the other thing that we need to understand. There are facility administrators and there are facility owners. As a facility administrator, there is so much power that you have that you can do certain things. So you have to, if you are an administrator and it's a private sector, you have to look for the owner and say, there's a contract that has come. These are some of the issues. What do you think? But they did not stop providing services. So they are able to say, can you please allow us to sign? Or they say, okay, let's pass it through our legal team. The lawyer looks at it if there are any issues, and then we proceed. And for the first time, there is no negotiation on prices because these are things that we have already gazetted, the benefits and the tariffs. So the communication has gone out.
So you're saying that all systems were ready by the 1st of October?
I have told you we had the NHIF system, we had the manual system, which was available, and the new system.
And you had 7,442 providers ready for the rollover.
Yes.
And yet we had problems. You would like to ask any question to the SHA people?
Yes.
This is the number to call.
Yes.
0800 720 601. That's 0800 720 601. Lydia is going to post it and also display it on the screen. That's 0800 720 601. What happens when I call this number?
You will ask all the questions that you have.
Who's going to give you? Who will pick this number?
The SHA staff. There's a call center.
Okay.
Yes.
It's a unified call center.
Yes.
From whatever part of the country you call.
Whichever part of the country that you call from, they will be able to solve your problems.
Okay.
Yes.
What are they likely to do? Walk me through the steps. If I'm at a hospital.
Yes.
And I'm being told that my name is not found in the system, are they going to tell me, Patia, huyo daktari simu?
Because they have been trained on how to handle the issues. It depends on what your issue is. They will be able to sort out, and even if they need to escalate, they will escalate it to the branch manager, to the regional manager, or to the HQ. So they have the matrix on what to do for each problems that you face.
Okay.
Yes.
When was this call center established?
It has been there.
Since when?
Since NHIF has been in existence.
Okay.
Yes.
So how come you didn't think about using it by the 30th of September? I'm still coming back into what were you people doing up to the 30th of September?
The people who need to use, many of them know this call number.
Patients are the ones who need to use.
Yes.
Many of them don't know this number, Doctor.
That's why I'm telling you. Now what we want to do is to simplify this and make it a smaller number. Like maybe 100, 147, 741. A simpler version that someone can easily remember when they have an issue. So that will take us some time, but hopefully we will move away from this, because recalling this number
it's a long number.
Yes,
so
exactly.
Is this number displayed at the health facilities? Because one of the things that you do is you walk into a health facility and the first point of call in the health facility, you say, you have an issue with SHA, this is it. You want to talk to a SHA officer, maybe there's a SHA officer stationed here, or this is the number to call. Is it there?
In the health facilities? Not yet. They haven't yet branded because this is for SHA. It's not for the hospital. This is for SHA.
Exactly.
Yes.
And everybody who is going to a health center across the country is a SHA member.
Yes.
Now it's not about NHIF.
Yes.
Everybody.
Yes.
As long as you are 18.
Yes.
Compulsorily. Yes. You are a member of SHA.
SHA. Yes.
So you go to any health facility in this country.
Yes.
You're most likely going to need.
But if you register, you will find that in your profile, that number. If you go to, you will find the contact, which email to use, which call center or number to call for help. Have you registered, Eric?
I have.
Have you gone to your Afya Yangu portal?
I went to Afya Yangu. You told me the password
your profile. Is wrong. It said your password?
But it's the wrong password.
Yeah, you renew because you see, that's your data. The same way you keep your PIN for M-Pesa secret is the same way. So you say reset password.
Okay.
And then you reset and you restart afresh.
And at what point shall I see this number? 800 720.
And that's why I'm telling you, we want to change this to a smaller number. Then that becomes a much easier number to remember, even offhand, that you don't need to look for it anywhere. And you don't need anyone to display it anywhere because it's a number that you easily know. You can easily remember it's 147. The same way you've seen, we are saying star 147 hash to register. It's the same way we will have a smaller number that will say 147 call.
I don't know if you're getting the gist of where I'm heading.
Yes.
This conversation I'm asking, that you've had a year to prepare. Since the moment the laws were signed in Parliament by the President,
yes,
they became law. And the President launched UHC in Kericho last year in October.
Yes.
It's been a year. It's been a year establishing the SHA board, you joining the board. It's been a year of transitioning from NHIF to SHA. It's been a year of getting everything else, all the ducks in a row. And it's you who decided that 1st of October was going to be the date. Not the law.
Yes.
So when you decided 1st of October was going to be the date,
so do you know what
things did you put in place to make sure that we are going to have a seamless transition?
A lot of things. The first thing that we put in place is the regulations. A law alone is not enough to implement. So that year, part of it was in court. So there was nothing that was ongoing. Because if the court says it's unconstitutional, there's nothing that you can do. Second part is to work on the regulations, public participations across the counties with the professionals. Third, we had to come up with the benefits and tariffs, which needed to be gazetted. That also needed stakeholder input. Looking at the budget, what do you have? Which one do you optimize? Which one is more important than the other? All are important, but based on the severity and based on the money that's available, you have to prioritize and say, we will start with this and not this as we move forward. So that year, a lot has happened. The second thing is, the fourth thing is how to transition. You know, you're establishing a whole new parastatal. So you have to do the whole HR instruments. Third, what has happened also, there was a transition committee also to do asset verification. So a year sounds too long, but when you realize what has happened, then you see a lot more has happened in those short period of time.
In all these things, was there communication?
Yes. It's maybe I understand you might have seen it many times because these things have been published. Even the regulations have been published in the newspapers. The tariffs have been published in the newspapers. For all these stakeholder engagements, when the transition committee was gazetted, it was also published and it was in the newspaper. So the question is, what kind of communication and is it everyone who hears it? Because it also depends on you people. And I have heard today morning City saying that there has been a lot of challenges, but all of a sudden the impeachment is the one that is in the center stage. But there is a lot of more important news that we keep on dropping. So yes, these things have been communicated, and that's why you also said, I was here, the presidential advisors were here. All this period, the CS, the PS, the former chair, all came here to just keep on communicating what are we doing and what's happening.
Actually, what we're saying is that it was inadequate. Because if it was adequate, there would be questions, yes, but there would be questions that are not related to the non-functionality of the system. Why am I saying this? If there's a power outage, if there's a glitch in the system, and you have all the documents that are required, that is something that is easy to sort out. But when everything that we have heard arises from people who have actually gone to hospitals and they are saying we cannot access, it can be a glitch. It can be a teething problem. But when you talk about how it is you've communicated to the provider to be able to give the information, that information should also have been given to the person who was seeking the service. Because if they were clear about it, then the hoo-ha that we heard would not have arisen, because it wouldn't have been you explaining. Because you've already explained to the provider. The provider would have said, we are in communication with SHA, and this is what needs to be done. Now, this number that you're speaking of would have come in very handy, because then one knows exactly who to call. Because even right there, when you have this problem and this glitch, you can call and say, look, I'm experiencing this particular problem. What do I do? How do I go about it? Now, if we do not have information as to how that particular chain of events could have moved to the point where the health seeker, the person who is seeking healthcare has, or his issues have been resolved, then the system still needs looking into. That is as politely as I can put it.
Thank you, City. Do you know, even after today, out of the 56 million Kenyans, maybe 1 million are the ones who will know this number?
True.
So that tells you that there is no enough messaging or communication that will tell me will reach every Kenyan.
But you know, there are ways of thinking about it.
That's why I'm coming. I'm coming.
If it's at the health facility,
let me finish so that we are on the same page.
Okay.
It can't be that this thing will be. Let me reiterate again. This number was for NHIF. We haven't even changed it.
We didn't even know it.
Thank you.
I didn't know it.
Thank you. Now that tells you that there is only so much that you can communicate forward. And that's what we want to change, because even communicating this is a big challenge. 0800722601. It's not an easy number to remember. In as much as it's a toll-free line,
yes.
it's not an easy number to remember. So we rather have a simpler number that we can easily say and everyone knows, SHA number. So for me, something like the 147 becomes an easier number that anyone can know. Register *147 #. You have a problem, dial 147. And that for me answers some of the challenges that we have faced.
Exactly. And by the 30th of this thing that you're saying today with so much clarity, Daktari,
yes,
is I'm sure you'd have had the same clarity on the 30th of September. And by then, as you're thinking, we are going to roll out this system on the 1st. And we are dealing with an entire population of 56 million Kenyans. And we want as many Kenyans to know what this thing is all about, for them to understand. One of the things is we have *147 #. Can we also make it a toll-free number, 147? Clear. Can we start talking with our service providers, the mobile service providers, to give us the 147 number so that it can be the SHA number? 147 is your SHA number you can call. *147 # is your USSD code. You can deal with SHA. Those ones. And then in every health facility, can it be clear? This is how we shall transition to SHA. From the 1st, when you come with your NHIF card, do not worry. You will be moving into SHA. If you're a contributor into NHIF, don't worry. You will be migrated to SHA. People have been receiving messages last week that you have been migrated, and they're saying, why are you forcing me to migrate into SHA? It's because they don't know. It's a lack of understanding and knowledge that this was what was going to happen anyway. If they had gotten a message, dear member, come the 1st of October, we are going to migrate you to SHA. People would be knowing. When you're getting all this pushback, Daktari,
yes,
it's because you thought about everything else, but you didn't think about the user.
The communication.
If you didn't think about the user, the user now is lost. And the user is not just the patient. The user is also that person who's working in that health facility, who has not been communicated to.
We have done, I think, almost over 10,000 users that we have trained. over the last 2 weeks. And these are from providers. We have trained over, and that's from just the private sector. And we have trained many other end users from the public sector as well, because the public sector wasn't even prepared as much as the private sector was prepared. So in terms of, is it adequate? Maybe not. Is it something that should come to an end immediately? No. It's a continuous process. So we will continue training, we will continue communicating, we will continue simplifying the processes that were there. And these are some of the issues. Like you see, this number has been in existence forever. The call center has been in existence forever.
Yep.
But you have been a member for NHIF for how long?
Many years.
Have you ever known you have a toll-free number to call if you have an issue?
Nope.
And that is the difference between NHIF and SHA. And that's what we will need to now inculcate. And that's the reason why we have everything of SHA is transparently done.
Okay. Now you mentioned this number.
If you look at the tariffs and the benefits, yes, City.
The question I want to ask is, when I call this number, what exactly will I get?
You will call, not to ask them how they are feeling, but you will call asking them what your issue is. So if you have your number, your card, and you have an issue in terms of how do I contribute, for example, where can I get services? Is the second thing. Is my contribution up to date? They will be able to answer all your questions. Where can I get these services?
And I am assured that when I call, there will be somebody who will respond.
Yes.
And if they don't respond, what do I do?
In terms of the line is busy, or in terms of the
hold on, we're soon connecting you to whatever it is you're supposed to be connected to, that sort of thing.
So the second alternative that you have is when the toll-free number is not working, is the branch or Huduma Center, where we have staff. So they will be able to answer the questions that you have.
And you train all these people?
Yes. And it's a continuous training to train them on what are the issues, how to solve them, how to escalate, what are the challenges. And it will take some time. Nothing, I'm not saying we have a perfect system.
Limited.
No, nobody's expecting a perfect system.
Yes.
But as we get to the top of the hour, the question I want to ask, does SHA have a communication department?
Yes, it does.
There's a reason why I'm asking this question. Okay. There's a reason why, and we will probably proceed with it when it gets to the next hour.
So we'll open the phone lines for anybody who has a question, of course, to ask the chairman of the Social Health Authority. And the phone lines, of course, are 07206. What's our number?
Start.
Okay. I'm glitching. The number will be shown by Lydiah online. I'm just thinking about this 0800 726 which is... Okay, our number will be on the screen. Call that number. The chairman of SHA is our guest this morning. What issues have you faced as you're accessing services? Or what information would you like clarity on? For example, maybe you received a message that you've been told you've been migrated from NHIF to SHA. What does that mean? Would you like some clarity on that? If you go to a health facility today, a level 2 facility, are you going to require a SHA? Do you need a SHA card? Do you need to register for your biometrics? And how do you do that with biometrics? And all this kind of information.
This is the Situation Room, the only way to start your day.